Good afternoon, and welcome to today's webinar on battlefield pain management, presented by our speaker, Dr. Kyle Giesler. We'll introduce Kyle further here in just a few minutes. My name is Joel Hewitt, and I'm a subject matter expert here at the Homeland Defense and Security Information Analysis Center, or HDIAC. So as we get started, the webinar chat function is enabled, so feel free to type in any questions as you go along. We'll have a question and answer session at the end. We are recording this webinar, and both the video webcast and a copy of the slide deck will be available for download from our website tomorrow, and the slide deck will be available at the end of the presentation. So briefly, some background regarding our center. We are a Department of Defense sponsored entity, one of 3 Information Analysis Centers, or IACs. Organizationally, we fall under the Defense Technical Information Center, or DTIC, and the Assistant Secretary of Defense for Research and Engineering. So our mission is to be the go-to R&D, S&T, and RDT&E leader within the Homeland Defense and Security community. We achieve this by providing timely and relevant information, superior technical solutions, and high-quality products to the DoD and HDS COIs and COPs. In doing so, we are able to help solve the most challenging technical problems facing the military and the government. We pursue this mission across 8 focus areas: alternative energy, biometrics, CBRN defense, critical infrastructure protection, or CIP, cultural studies, homeland defense and security, medical, and weapons of mass destruction. Our external subject matter expert network is a critical tool in achieving this mission. Our SMEs, like Kyle, help us provide the military and government with the most up-to-date and cutting-edge information. If you have expertise in one of our focus areas, we very much encourage you to apply. So Dr. Kyle Giesler is a postdoctoral scholar at the University of California in Berkeley, where he investigates non-viral delivery strategies for CRISPR-Cas9 and other emerging biologics. Kyle received his doctorate in medicinal chemistry from Emory University in Atlanta, Georgia, under the tutelage of Dennis Leota, working on novel small molecules for the treatment of HIV and other chronic viral infections. From 2015 to 2017, Kyle worked at GlaxoSmithKline, and his research interests include pharmacology, drug delivery, immunology, virology, and high-risk drug discovery ventures. He also has a keen interest in medical research related to military operations, regenerative medicine, medical countermeasures, and CBRN defense strategies. And with that, Kyle, we welcome you, and we hand it off to you.
Thank you, Joel. I appreciate it. And thank you all for joining me here today. So the focus of today's presentation, of course, is on battlefield pain management, which is becoming more and more of a focus point in the U.S. military today. And this is largely due to the fact that survival from battlefield injuries has significantly increased over recent years. This is largely due to improved battlefield hemorrhage controls, improvement in resuscitation, increased blood product availability, surgery, and rapid evacuation to, say, higher levels of care. But improvements in early pain management on the battlefield have evolved far more slowly. Acute battlefield injuries, by far, result in severe or moderate to severe pain and ultimately require immediate intervention. And I'd like to note that if you don't treat these injuries early and manage pain, the ineffective pain management has both long and short-term consequences, particularly the development of, say, PTSD and/or chronic pain, depression, and other mental health disorders as well, because pain and mental health are so intricately intertwined. I'd like to point out that pain is only second to trauma experience on the battlefield, with blast injuries accounting for about 56% of all injuries for warfighters, with gunshot wounds coming in second at 32%, and to a lesser extent, motor vehicle crashes and non-combat injuries. And most of these injuries that I just mentioned there typically result in pain scores on the scale below that you can see 5 or higher, that is, ranging from severe to the worst possible pain. Now, when it comes to treatment options, there are a wide variety of drugs on the market, such as sodium ion channel inhibitors, NMDA antagonists, NSAIDs. The list goes on and on. This only represents maybe a handful of all known currently available analgesics. But when it comes to military medicine, several factors have to be considered. For instance, a drug should ideally have a fast onset time, can be administered by the patient or warfighter themselves, should have sustained analgesia, and shouldn't be addictive. There are all these other properties that are associated with the ideal pain regimen, and unfortunately, given the complexity of the injuries experienced on the battlefield, the ideal pain regimen has yet to be found, and there is no such thing as a universal approach for treating such injuries. When it comes to where in the body do these particular analgesics operate, that ultimately depends on the kind of pain that's being treated. For instance, local anesthetics and nonsteroidal anti-inflammatory drugs, or NSAIDs, they typically operate at the nerve endings for nociceptive pain, pain that arises from distal tissues that may be damaged by, say, injuring your shin or whatever have you, something that produces the inflammatory cytokines or prostaglandins that is then sent up the nerve signal to the brain to receive the pain signal. And NSAIDs, of course, counter that message being sent. Local anesthetics apply a little higher up the nerve, and then you have the alpha-2 adrenic agonists operating at the dorsal root ganglion, and then you have gabapentinoids, opioids, tricyclic antidepressants, SSRIs. We start getting higher up the central command center here, if you will, when it comes down to where is pain being processed, how is it being processed, and these agents typically operate in the central nervous system itself to stop the signal altogether. So the more potent analgesics operate in the brain, and the less potent analgesics tend to operate at the nerve endings or distal tissue locations. Morphine and opioids in particular have a long history on the battlefield, to say the least. Poppy seeds and opiates have been around since 4300 BC at least, and they were protected vigorously along the Silk Roads. But morphine itself, interestingly enough, wasn't used in pervasive military medicine until the German pharmacist Friedrich Wilhelm Sertiner crystallized the compound from poppy flower in 1804, and he originally thought that this would be a non-addictive form of poppy, although morphine is the active ingredient of poppy that is known to induce analgesia. This wasn't known at the time. And once morphine was crystallized and isolated, it was realized that, well, we can supply this to warfighters on the battlefield. And so morphine was widely distributed amongst members of the Civil War. However, it was touted as a miracle drug. But soldiers quickly began to develop morphine addiction, opioid addiction, and dependence right then and there on the battlefield. And this continued into World War II, unfortunately. So the warning signs of morphine and opioids in general started to present themselves early throughout the course of military history. Nonetheless, today morphine is generally regarded as the staple and standard of care for pain management for military personnel. Morphine is available as morphine sulfate at 10 milligram auto-injectors for personal use, which are usually used for intramuscular injections. But the intramuscular injections tend to have inconsistent absorption, a delayed onset, and compromised analgesia when not used appropriately. This is where IV morphine comes into play and provides a far more rapid and consistent pain relief where IM morphine fails. But there are other places as well that also have warranted the use of opioids on the battlefield beyond morphine. It turns out that most people, whether you're a warfighter or a civilian at home, don't tend to like needles, and there are other applications by which opioids can be delivered to produce analgesia. So Actique is a fentanyl lollipop, fentanyl being a synthetic opioid with about 100-fold more potency than that of morphine, and it's essentially a fentanyl lozenge on a stick. And what this lozenge does, this is not an oral delivery strategy, mind you. This is a subbuccal or buccal mucosa delivery strategy, where the lozenge is applied directly into the mouth, and absorption occurs through the intricate and vascular vascularization of the cheek muscle and of itself, which allows lymphatic access into the bloodstream, bypasses first-pass metabolism to provide relatively fast analgesia. And fentanyl was approved in 2004 and added to the Tactical Combat Casualty Care Guidelines as an option for battlefield analgesia. And it's easily, this particular lozenge is easy to administer. I noted earlier that this is not an oral delivery strategy, so the patient or warfighter does not have to swallow this agent. It just has to stay adhered into the cheek muscle itself. And once the desired level of analgesia has been reached, it can be removed. This technology is heavily used right now through the U.S. Army, the Navy, and the Marine Corps with high degrees of success. But you can imagine with a product like this, it's tightly regulated, and all these fentanyl lollipops are adequately accounted for, and tight controls are in place. But sometimes fentanyl citrate is not appropriate, and sometimes a higher degree of analgesia is required. And in 2018, the FDA approved Dsuvia, which is another synthetic opioid with about 500-fold more potency than that of morphine itself. This is approved for the treatment of moderate to severe pain. And this is unlike fentanyl, or the acute lozenge lollipops, if you will. Dsuvia is a wafer that is applied below the tongue. So again, this is not oral, but it's instead sublingual delivery to take advantage of the fact that we can get drug delivery through the vascularization of the mouth and into the blood. The Dsuvia was developed in collaboration with the Department of Defense and Acell RX Pharmaceuticals. And one of the questions that the general public had about the approval of Dsuvia is why is the federal government looking at, say, another synthetic opioid in the midst of an ongoing opioid epidemic? And the former FDA Commissioner Scott Gottlieb asked the same question and thought this was worth addressing. And his response, to summarize, is more or less that there is a sufficient need for opioids for the treatment of pain because they're so effective, and each of these drugs that go through the gates of the FDA are approved on their own merit, which is important, I agree with. And so the Department of Defense, of course, advocated for the use of Dsuvia because it has many advantages that conventional intramuscular injections or IV may not be possible or just fall short. And so, nonetheless, this public outcry very much set the stage, really, for the federal government and the DoD to continue pursuing non-opioid options. But with that in mind, prior to the release of Dsuvia, the DoD already knew that this was going to be a somewhat controversial drug, and with collaboration along with the FDA, Dsuvia is not available in retail pharmacies, and it's only available strictly through hospital settings, surgery, and military personnel for severe pain. This cannot be approved or acquired through the general consumer by any ways or means. The next question, of course, is if opioids are starting to become phased out or unpopular because of course, their addictive properties, what makes them so great? Why are they so good at what they do? And this, of course, we have to go into a little bit of pharmacology here. So when using morphine as an example for a canonical opioid, when morphine binds to the receptor, the mu-opioid receptor, it's very similar to what happens when a fly touches, say, a Venus flytrap. For a Venus flytrap is equipped with these little trigger hairs in the middle, and when 3 or 4 of those trigger hairs are touched, the trap itself closes and its prey is left inside. And biology also operates in this same fashion. So the mu-opioid receptor is lined with a bunch of trigger hairs on the inside, or, to be more technical, amino acids that actually constitute the receptor itself. And when morphine binds and touches a certain subset of those amino acids or trigger hairs, one of 2 things can happen. The G-alpha I signaling pathway that's well known for these receptors goes into effect. These G-alpha I proteins are essentially coupled to the receptor itself. Binding to an opioid causes the receptor to wiggle, and that wiggle movement is then captured by the G-alpha I proteins below, and then that triggers a series of downstream signaling pathways that reveal the synthesis of, say, cyclic AMP, sodium or potassium, in this particular case, potassium ion efflux, and this produces analgesia. The other thing that can happen when opioids such as morphine bind the mu-opioid receptor or other opioid receptors, I believe there are 4, is they can also activate the beta-arrestin. And when beta-arrestin, as its name suggests, arrests opioid signaling altogether, what happens here is that when this protein that's also coupled to the receptor, it becomes activated. The receptor is internalized by the cell, so the signaling pattern itself is completely compromised, and then it is later presented back on the cell surface. And what this does is it effectively silences the signaling pathway associated with morphine and other opioids to lead to respiratory suppression, constipation, and tolerance, which of course are the critical and undesirable effects of opioids themselves. And here I have shown the chemical structure of morphine, and what I want you to appreciate for a moment is, as a chemist, the structure is extremely rigid. It's not flexible whatsoever. So every time morphine binds to the mu-opioid receptor, it binds and hits those same trigger hairs, those same amino acids every single time. So its pharmacology is very reproducible, it's well known, and this tends to be true for other drugs as well. Opioids, of course, following that statement, have a significant risk-to-benefit ratio. There are advantages of opioids. They're highly efficacious for the treatment of moderate to severe pain. And they're relatively safe as well when administered under the medical supervision, when the dose is known, when the indication is known. And in contrast to, say, NSAIDs or other forms of analgesics, opioids do not produce end organ toxicity. NSAIDs, for instance, are known to cause gastrointestinal bleeding, kidney failure, and come with some severe cardiovascular risks, which can limit their over-the-counter or widespread use. And interestingly enough, there's also no ceiling effect associated with opioids. That is to say that more opioids produce more analgesia. Now, that in mind, some of the disadvantages, which I previously mentioned, one, of course, is the high potential for abuse. Opioids, like other illicit drugs, of course, opioids are not illicit, but drugs that make people feel good have a high potential for abuse. And respiratory suppression is, of course, the causative mechanism by which opioids induce death, more often than not. Tolerance, of course, although there is no ceiling effect associated with opioids, in general, when you agonize the receptor with more and more morphine, or more and more fentanyl, or more Dsuvia, the receptors begin to disappear from the cell surface, and tolerance begins to develop as more opioid is required to potentiate the residual receptors on the cell surface. And some other undesirable side effects that are caused by opioids include constipation, nausea, and vomiting, and this is because these clinical manifestations are all, of course, tied to mu-opioid signaling pathways. So then the question becomes, well, where are we going with non-opioid analgesics? Has this field been successful, and what are some of the challenges? And unfortunately, this field has been extremely challenging. In fact, many big pharmaceutical players such as Merck, Pfizer, Johnson & Johnson, etc., have shuttered their doors to non-opioid analgesic programs. And there are a number of reasons for this. I would say one particular glaring reason is that animal models rarely predict human efficacy. And this is particularly true with analgesics. Oftentimes when these pharmaceutical companies evaluate the potential of a new analgesic, what they'll do is they will have an assay, or they'll have a rat on a hot plate, for instance, and they'll feed the rat, say, a fixed amount of opioid or non-opioid analgesic. And what they'll do is that they'll monitor how often the rat licks itself when the heat is turned on the hot plate. And that's really the only indication that they have to the success of that assay. And there are others as well, but they're very similar in nature, where they're just looking at the overall behavioral profile of an animal when it's on the medication versus when it's not. And this is somewhat a flaw in preclinical target validation, because it's very challenging, because animals by nature are far more stoic with their ability to, we really don't know how they feel pain, because they don't present it in the same manner that humans do. And the other thing as well is that pain in general is a very subjective sensation. Despite the fact that it's ubiquitous amongst the human population, one person's 7 on the pain scale could be another person's 4. And the only insight that clinicians really have to how someone is feeling or to their degree of pain is a survey. And of course, as I mentioned, with someone's having a 4 or 7, those results can be significantly skewed, and it's difficult to achieve statistical significance or conclusive results in clinical trials. Another real burden is that the molecular mechanisms of pain are incompletely understood. We know that, say, for instance, the mu-opioid receptors are heavily involved in pain, just as you'll discover that the NMDA receptor is. So are other receptors throughout the body, sodium ion channels. But how they all come together to provide the sensation of pain is far less clear. And although it's information that pharmaceutical companies are desperately trying to capitalize on, nobody knows the answer or how to quite characterize it. There's also a very high placebo effect when it comes down to new analgesic clinical trials. Oftentimes, when you provide somebody a pill and you tell them they're going to feel good, chances are they're going to feel good. This has been documented several times in clinical trials, and new analgesics are significantly burdened with a high placebo effect that is very difficult to tease out and to evaluate the true clinical and therapeutic potential of a drug, say, versus the placebo. And despite all these challenges, there have been a few drugs that have made it to the clinic, but the one I really want to talk about now that's starting to experience a resurgence is ketamine. Now, ketamine, its chemical structure I have featured right here, is an NMDA receptor antagonist, which we'll go into shortly here. The compound was discovered in the 1960s, and I think the first clinical trials for ketamine were, or the human trials at least, were in the mid-1960s, perhaps 1964, and the FDA approved it in 1970 as a sedative. I say that it's a sedative because that was the specific indication that the FDA has cleared this compound for, nothing else. And as a sedative, ketamine saw pretty significant and widespread use during the Vietnam War, but it shortly fell out of favor as newer anesthetics came onto market. Ketamine is a dissociative anesthetic, and it was later revealed that at sub-anesthetic doses, ketamine produces analgesia, or pain relief. And then the other thing that's really interesting about ketamine is that with this nitrogen atom present on the molecule itself, ketamine can be formulated as a salt. It's relatively lipophilic. And so because it can be formulated as a salt, it can be formulated in various different formulation strategies, whether you have an IV injection, IM, intranasal, oral elixir, rectal, intrathecal, transdermal. These are all possible because the molecule has this property of becoming a salt, or it can be delivered as is in its lipophilic form, whatever the application might have you. And although it's not FDA approved to treat pain, lots of doctors in the emergency setting and hospital settings are using it off-label to treat acute pain, particularly post-surgical pain and pediatrics. But again, there's no standardized dose or guidelines because it's not FDA approved, which is somewhat challenging. Ketamine, as I mentioned, produces dissociative anesthesia, and this comes down to atar analgesia. Had a minute to say that out loud there. For ataraxia, meaning without a soul. What ketamine does is that actually it cuts off signaling between the thalamus, or the gate of consciousness, to the neocortex, so that induces a state of comatose. And ketamine is not alone in this effect. Other NMD antagonists, for instance, phencyclidine, or bath salts, the colloquial term for bath salt drugs, is another NMD antagonist that also produces these effects. So with said drug, hallucinations and a dissociation from reality are relatively common, especially at dissociative concentrations, and not so much at sub-dissociative concentrations that are required to induce analgesia. What's nice about ketamine is that it has a fast on and fast off half-life, which means you can induce analgesia very quickly, and then you can remove the analgesia if so desired to swap out for a more robust pain management strategy, say morphine, later down the line. And a lot of people that take the opioids versus ketamine, several studies have compared the two. What is the efficacy profile of ketamine, say, versus morphine? And it turns out that they're pretty comparable. Most people that experience moderate to severe pain tend to note a 3 or 4-fold reduction in pain scores, which is comparable to that of morphine. The other nice thing about ketamine as well is that in contrast to the respiratory suppression observed for morphine and other synthetic opioids, ketamine does not induce respiratory suppression. Rather, bronchodilatory effects are observed, so no closure of airways or maintenance of the airway is necessary for ketamine-based therapies. Antidepressant properties have also been observed, which I'll talk about a little later. And some other side effects of ketamine include increased blood pressure and heart rate. This has been ubiquitous across various dosing strategies, no matter if it's at 0.25 mg per kg, 1 mg per kg, or lower or higher. It's always been observed that an increase in blood pressure and heart rate is predominant with ketamine therapy. There is a potential for dependence here. Ketamine is considered a Schedule III substance by the Drug Enforcement Agency and is often used as a party drug. And one of the common side effects, of course, that we also see with opioids is nausea and vomiting. Now, ketamine actually comes in 2 distinct flavors, if you will. And this is a stereochemical consequence of the molecule itself. So the best way I like to describe this is there's R-ketamine and S-ketamine, and the relationship between them is that they're the same but different. Very similar to your hands. If you look at your left hand and your right hand, you can clearly tell that they're the same but different. And the exact relationship between the two is that they're non-superimposable mirror images. And in chemistry, what this means is the relationship between 2 molecules that are non-superimposable mirror images of one another, they are enantiomers. And what this means for the properties of the drug is that 2 compounds can be enantiomers, but one may bind the receptor and the other does not, because in effect they are the same but different. And nature knows the difference. The binding of those various amino acids in an ion channel or a receptor is very sensitive to the geometry of the molecule. And if you were to, as a mental exercise, take R-ketamine and S-ketamine and try to superimpose them on top of one another, you will find that you will not be able to. There's going to be a distinct difference between the geometry of R-ketamine versus S-ketamine. And there are some advantages of producing a single enantiomer over another. For instance, S-ketamine has 2-fold the analgesic potency of racemic ketamine. Racemic ketamine having a 50-50 mixture of both R-ketamine and S-ketamine. And with that, S-ketamine is also slightly more potent when it comes to its affinity for the NMDA receptor itself. And this translates to, a wider therapeutic range, interestingly enough, a faster elimination time to suggest that S-ketamine may be more predisposed to cytochrome P450 enzymes or MAOI proteins, which also contribute to the oxidation of the nitrogen atom and elimination of the drug itself. And S-ketamine was recently approved by Johnson & Johnson not too long ago, I think it was earlier last month, for the treatment of treatment-resistant depression, and which they bottled up and called Spravato, which again I will talk about shortly in just a moment. When it comes down to ketamine's mechanism, so ketamine is considered an antagonist. In contrast, morphine is an agonist. In pharmacology, an agonist agonizes the receptor, whereas an antagonist stops signaling through the receptor. So the NMDA receptor itself, N-methyl-D-aspartate, is the endogenous ligand to this receptor. There is an allosteric binding site, as you can see in this figure, where ketamine nicely lodges itself in. And when ketamine positions itself in this binding site, it stops ion flow through the NMDA channel itself. Now, what's interesting about NMDA, the receptor, is that it's a ligand-gated ion channel, so that ions flow only after the receptor binds to glutamate or glycine. And what ketamine does is that ketamine cuts off that line of communication altogether. So the receptor could bind to glutamate or glycine, but then it would fail to release calcium ions or sodium ions, and I also believe potassium ions as well. So it abrogates signaling altogether. And it's a non-competitive antagonist as well, so it doesn't actively inhibit the channel. It doesn't lodge itself in the middle of the channel. It lodges itself somewhere else in the channel at this binding site which induces a conformational change, and that conformational change abrogates signaling. And this reduces the presynaptic release of glutamate and potentiates the effects of GABA, and NMDA, being predominantly expressed on the central and peripheral nervous systems, has a lot of interesting neurochemistry associated with signaling pathways, again, particularly consciousness, again, between the thalamus and the neocortex. Ketamine has been approved by the Committee on Tactical Combat Casualty Care List as an approved analgesic since 2011, which is really interesting because although the Department of Defense has recognized that ketamine is an approved analgesic on the battlefield, the FDA has not. No drug company to date so far has successfully put ketamine through clinical trials just yet for the treatment of acute pain. This, of course, is changing in just a moment. I'll tell you that in the next slide. And despite that ketamine has interesting analgesic properties comparable to that of morphine, no Navy SEALs routinely carry ketamine. But it definitely has significant advantages, and one in particular is with respect to PTSD and the treatment of acute pain early on, because as I mentioned previously, pain and mental health are inexorably linked together. And this one particular study evaluated the effects of ketamine on warfighters who sustained severe burns and found that those that received ketamine were at a lower risk of developing PTSD, or PTSI here, versus the placebo group. And again, the early treatment of battlefield injuries can stave off the production of later mental health issues down the road. Some of the tactical benefits of ketamine include a minimal impact on carrying capacity. It doesn't require much drug to produce analgesia, especially if it's an intramuscular dose. Ketamine is a solid, can withstand environmental extremes, such as the dusty and often arid temperatures of the desert, and also the significantly colder temperatures of like the Arctic tundra. And as I mentioned previously, ketamine provides fast and consistent pain relief that's on par with morphine. That's also very advantageous. And it's well suited for individuals who are also at the risk of shock or going into shock. In fact, I believe if you're unable to fight and you're at a risk of shock, the DoD recommends intramuscular ketamine. And if you're unable to fight with no risk of shock, oral fentanyl citrate or those acute lollipops are the preferred method for analgesia at that rate. And then finally there, if you're able to fight and there is no risk of shock whatsoever, then Tylenol and meloxicam are the preferred. But opioids increase the individual's risk from suffering from hemorrhagic shock, and so ketamine fills this niche where opioids cannot. I see a bright future for ketamine in military medicine. FDA approval for acute pain would be the next barrier to be overcome. And the reason for this is that it's because ketamine is so off-label, there's no consensus in the guidelines. What doses should be required? What do we need to deliver to patients to curb their analgesia? And for what indication? Pain is very ambiguous. Is this pain coming from dental pain, lower back pain, leg pain? Of course, blast injuries are very complex, and it's very difficult to assess for a given injury what kind of pain medication would be best. But a standardized dosing regimen and guideline would be the first step towards that path. And then, of course, the question becomes, well, what kind of delivery device should ketamine be administered through? An infusion pump, an auto-injector. IX Biopharma right now are proceeding wafamine, which are ketamine wafers, very similar to, say, the Actique lollipops, or Dsuvia, rather. It's probably more akin to Dsuvia, through clinical trials right now. I believe it's in phase 2, and this is also for the treatment of moderate to severe pain. They found that it's been well tolerated. I think the company is developing at where it stands, maybe 50 to 75 milligram wafers. And it's proceeding through quite nicely at this point in time. The intranasal delivered ketamine is not ideal for dusty battlefield environments, and you could see why that would be. And the other question becomes, is there a civilian market for these devices? You know, most civilians are within 5 minutes from emergency services. And emergency services, of course, carry the full gamut of medical equipment, whether it be IM, IV equipment in particular. And so there really wouldn't be a need for an intramuscular autoinjector for ketamine in the civilian market per se, because there are just so many other medical equipment that are available to the EMS workers at the initial point of care. The assessment for abuse potential should also be considered. Ketamine does have some abuse potential. Again, it is a party drug that its dissociative properties are somewhat desirable, but again, at analgesic concentrations, these tend not to be an issue. But dissociative effects on the battlefield should be considered because that could definitely detract from key missions, or certain aspects of military life could be compromised by dissociative hallucinations from warfighters on the battlefield. Other indications that military personnel could really benefit from ketamine are, in particular, depression. Ketamine was just recently approved for the treatment of depression, Johnson & Johnson's Spravato product. And this is highly significant because where it stands right now, mental health is becoming more and more of a priority, or on display, rather, in the military. I think that the U.S. Army right now, where it stands, is the suicide rate is increasing significantly. And there needs to be a means to curb depression, warfighter depression, which ketamine may also be a very useful medication for that. And post-traumatic stress disorder as well. Exposure to combat increases your incident risk for PTSI, PTSD, and ketamine also has been shown to alleviate that. So we really have a three-pronged drug here, which is highly unusual in the sense of pharmacology, where ketamine has been shown to have analgesic properties, antidepressive effects, and also PTSD effects. So one drug, three indications. That's quite novel and quite interesting, whereas the traditional sense of pharmacology is one drug, one indication, and ketamine is a premier example of where that's changing. Now, in the academic setting, what people are tending to do towards safer opioid analgesics is, the question is, how can we reduce this beta-arrestin pathway altogether? If the opioid signaling pathway has two distinct outcomes, whether it's analgesia or the beta-arrestin, can we design a molecule to dial out the beta-arrestin pathway? And this was a paper published in 2016 in Nature. And what the researchers found is that they identified compound 12 through a high-throughput screening effort. And what they discovered is that compound 12 is able to potentiate the analgesic pathway, and you can see that here in red on the left. You get a nice dose-response curve. But it does not potentiate the beta-arrestin pathway on the right. You can see we don't get a nice dose-response curve there. So this indicates that compound 12 is able to, stimulate the desired pathway for mu-opioid receptor signaling and not stimulate the undesired pathway for mu-opioid receptor signaling. Now, this was published in 2016. I haven't seen any reports recently on this compound 12 being taken further to clinical trials. Again, there are a lot of barriers that I previously mentioned as to why that might be the case, or if a new compound has already been taken to market or being pursued right now by some company. Other compounds that are also being pursued are sodium ion channel inhibitors. The pufferfish toxin, tetrodotoxin, is currently being pursued as a as an analgesic for battlefield use, which is really interesting how you can convert essentially a potent neurotoxin into a next generation analgesic. And with that, I think that concludes. Actually, no, here we go. Their conclusion slide is right here. So opioids do remain the preferred analgesic on the battlefield. Morphine, fentanyl, Dsuvia in particular. They are effective drugs, but there are many caveats, of course, with respiratory suppression, tolerance, and addiction being some of the top three players and why these drugs are undesirable. But then again, there are many challenges associated with developing non-opioid analgesics, such as a high placebo effect, the inability of animal models to predict clinical efficacy, and therapeutic misconception. And ketamine is an attractive NMDA antagonist with analgesic properties that has seen extensive battlefield use. There are significant benefits over morphine. Of course, it doesn't induce respiratory depression. Delivery devices or formulation strategies are needed should be suitable for the DoD. IV ketamine, of course, is an immediate access. Intramuscular ketamine is also possible, but it appears that right now sublingual wafers or wafamine may be the next step in battlefield analgesia from IX Biopharma. And new opioids with fewer side effects are being pursued by academia, but it remains to be seen if they will actually make it to the clinic at this time. And with that, I will take any questions that you guys may have.
All right, Kyle, thank you so much. Yes, as you said, we welcome all questions, and we have the first one in from Dwayne Faulkner. Have any provisions been looked at to avoid paradoxical disinhibition with ketamine usage?
Not that I'm aware of. I'll have to get back on that. Paradoxical disinhibition with ketamine usage. I don't know. Not at this time. None that I'm aware of. I'll have to look into that. Sorry.
Dwayne, we will look into that and initiate what we call technical inquiry and get an answer to you in the near future.
Yeah, that'd be great.
So as we have other questions come in, Kyle, I just wanted to ask, I know there's a lot in the popular media of the phenomenon of microdosing, and on his question whether that has anything to do with ketamine and whether there's any potential for that to be of any use, whether peremptory or a microdose of ketamine in cooperation with an opioid.
Yeah, so there has been a lot of interest in microdosing, and on that, I would say that I see there is a clinical utility for microdosing. Again, the dose, what is considered a microdose, needs to be teased out. I don't think that's been really evaluated just yet. Preemptively, it would be interesting, given ketamine's bronchodilatory effects, for instance, if that would somehow offset the respiratory suppression that opioids provide. Again, the dose ratio there should be teased out. But I've heard of microdosing in the sense of being more used for, say, psychedelics in particular. Psilocybin, for instance, is also being used or investigated right now as a potential, not analgesic, but just for some context here, it's just so interesting to see how mental health and, again, pain are so interconnected. So again, the microdosing strategy with psilocybin to somehow change the brain's cognition on what pain is and the perception of pain, I think also follows suit with NMDA antagonists like ketamine, phencyclidine, and other, say, 5-HT1A agonists as well. And so it would be interesting to see just how microdosing in conjunction with an opioid would be beneficial over, say, preemptively treating just with ketamine or just with an opioid, or ketamine and then transitioning to an opioid. What if you had a little bit of a microdose of both? That's an interesting question.
We have another question from Peter who says, can you comment on the incidence rate among warfighters of severe tingling effects which can occur as a consequence of taking opioid analgesics? Is this a concern?
I do not have any data on that at this time, but what I do know is I think back in 2005, the DoD, with respect to, say, abuse, I don't have any data on the tingling sensations, but with respect to abuse at least, I think back in 2005, 75% of those warfighters surveyed said that they didn't abuse opioids, and that number has now diminished to, say, 50% in self-reported surveys. So there's definitely a need there's definitely a trend here in abuse, it seems, in the literature setting amongst warfighters. For tingling sensations, that is a little more esoteric to me. I don't know. I'll have to get back to you on that one as well.
Yes, Peter, we'll look into that further on also, and we'll get back to you. So we welcome any further questions here for another minute or so. Final question from me, just as a point of information. Kyle, you said that ketamine is a fast-on and a fast-off medication. What's the how does it wear off? Does it simply wear off, or does it require another intervention to stop its effects?
No, it's self-resolving. So ketamine, fast on, fast off, it's metabolized very quickly. So, and my speculation is that the primary mechanism of metabolism is oxidation of the nitrogen, which makes another molecule altogether with no dissociative effects and no analgesic properties. So after you administer ketamine, it binds the receptor, but then the blood flow is continuously pumping molecules to the liver, where then subsequently oxidized and then excreted either via in the urine or defecated later. And I think that, what happens is that the metabolism of ketamine is just extraordinarily fast. And so what future generations of ketamine might produce are versions of ketamine with reduced hepatic extraction, which could confer a longer half-life and less dosing frequency. But where it stands right now, yes, fast on, fast off, and that's just by virtue of the metabolism of the product itself.
Good deal. All right, well, with that, we want to thank everyone for their attendance. And Kyle, thank you again especially.
All right, thank you, Joel.
Thank you all.